And to round out, I know people are also excited about this one. I've heard several things. We have Healthcare Foundry. Healthcare Foundry is a platform to launch built for purpose technology enabled healthcare organizations. They aggregate the leading talent in the market to solve specific problems in healthcare that improve the lives of patients and lead the industry towards a more rational, sustainable, and patient-centered model of care. To discuss this, we have Jonathan Rhodes, who's the vice president at Healthcare Foundry and has been with the team since 2022. Prior to joining Foundry, Jonathan's career focused on sourcing, co-developing, investing, and integrating healthcare startups into large legacy health enterprises, such as Cerner, Cleveland Clinic, and most recently United Health Group / Optum. Through these roles, he has made a lasting impact on various areas such as women's health, kidney care, telehealth, remote patient monitoring, and oncology care. He holds a BS in Business Administration from Dallas Baptist University and an MPH in Healthcare Management at Yale. While Jonathan considers Boston home with his wife, 2 children, and bulldog, he's a diehard New York Yankees fan and can be found in the Bronx most Saturdays. Very cool.
All right, guys, thanks for having me. And I want to first give yourselves a round of applause. If you've been through 8 hours of presentation today, it means because you're very passionate about advancing oncology care. And so thank you for coming. They say that they save the best for last. This is what they say. They originally had me actually at 4, which is actually when the marching band arrives. And I just want to say thank God that someone didn't show up, because I cannot compete with that. I don't think anyone can. We're excited to share a little bit about Oncology NeauxCo and Healthcare Foundry. Before I do that, I want to say, our presentation is probably a little bit different than some of the other ones you've seen today. The first is I'm not clinical, and so you'll have to go easy on me. But the second is I'm actually here on behalf of a healthcare venture studio called Healthcare Foundry, where we launch healthcare companies. I lead the oncology work and have spent the last year working on this company, and excited to share more about it. The name is Oncology NeauxCo. That is not actually our real name. It is our stealth name. It's something that silly thing that us venture studios do often, and so you'll have to bear with us with the name. But Oncology NeauxCo is an innovative risk-bearing oncology company, or a value-based solution that's built for clinical impact and scale. So put very simply, we take on risk from payers, and we guarantee savings to them. And then we work with the members and the oncologists that the members see. And we work to ultimately reduce savings. We share those savings with the oncologists. That ultimately creates a win-win for everyone involved. Before I talk a little bit about Oncology NeauxCo, I wanted to give you an overview of Healthcare Foundry. Healthcare Foundry was launched in 2016, but we recently kind of revamped our efforts in 2022 with an expanded team. We're funded by Maverick Ventures, and we've launched 5 healthcare companies since 2016. I can go through some of those. Trellis RX is a 340B specialty pharmacy that sold to CPS Solutions for a little under $1 billion a few years ago. Lightship Health is a remote clinical trials business who was launched prior to COVID, so we got pretty lucky with timing there. Belong Health launches dual special needs programs with regional payers around the country. House RX is a dispensing pharmacy and oral pharmacy that works with practices from around the country. And then Gather Health is a value-based care at-risk primary care group that was launched in 2022 in Massachusetts, and hoping to expand down here in the region. And so I would say one thing about Healthcare Foundry is we look to solve some of healthcare's toughest problems. And typically, the first thing we do when we launch a new company is we look for the right people and the right minds to ultimately solve the problem that we're looking to solve. And so this is the team that we've put together. I consider these guys that you see on the screen the Avengers of value-based cancer care. I know that seems a little bit like an overstatement, but I can assure you that the last year in working with these guys have been one of the highlights of my career. Starting with Alon and Rob, those are kind of my partners in crime at Healthcare Foundry. Moving to the clinical team, we've got Roy Beveridge, who's the former CMO at both Humana and US Oncology. Zeke Emanuel, who is an oncologist by training and was one of the architects of the Affordable Care Act. and really understands physician incentives better than probably anyone in the country. And then Justin Beckelman, who's tested a lot of these clinical models within Penn, where he leads the Center of Innovation there. We also have other operational advisors who just have really great backgrounds from kidney care to home-based models who just really help lean into some of our operations. And so, as I've mentioned before, these guys have been just a joy to work with. Realizing that I skipped a little bit over myself, and so I'm happy to share a little bit about myself as well. But prior to joining Healthcare Foundry, I worked at Optum, where I led corporate partnerships and M&A for Optum Health Group. So we dealt with a lot of the high-risk condition categories, from cancer to kidney care to women's health, MSK, and others. And us as a payer organization, we do what every payer does, and we look at areas of spend. We start at the highest and we work our way down to the lowest. And when we do that, oncology is always at the top of the list. Oncology is about 18% of all spend for an average payer plan, especially Medicare Advantage. It was growing at roughly an 8 to 10% CAGR. When you look at the market as a whole, it's about a $210 billion market. A fun fact, the only market that is this big and that's growing this fast outside of cancer is actually electronic vehicles. So it's a massive market with a lot of opportunity, but it's also a complex market, right? And so, there's a lot of reasons to want to build a company in this space, but a lot of scary reasons as well. And so, but when you see a trend line that's growing an 8 to 10% CAGR, it's a $210 billion TAM, and you're a payer, there's typically one thing that tends to happen, and that's risk delegation. We've seen this come in primary care. We've seen this happen in kidney, and it's about to happen in oncology, and it's been happening over the last few years. But when you look at the dynamics specific to value-based care within oncology, they're very complex dynamics, right? The oncologist traditionally does not want to take on risk. They traditionally fear downside risk because they make a lot of their money on drugs, which is totally understandable. It's where the incentives are. But secondly, they don't have the infrastructure in place to really negotiate risk contracts. I mean, these things are really complicated. Negotiating the benchmarks is a complex process. So even for large groups around the country, it's something that they struggle with. And so you have these unique dynamics where you have a tipping point of sorts where you expect, a risk-bearing solution to emerge, but then at the same time, scalability is a big concern. And so we as NeauxCo, we said, what if there was a scalable platform where we can truly create a better member experience, where we can drive better outcomes, and just have the opportunity here to make a tremendous impact for cancer care delivery. So, we've talked through some of the, macro trends, I think, with cancer, but also wanted to walk through some of the micro trends as well. When I was at Cleveland Clinic, I worked in their cancer institute for about a year. And I'd meet about once a week with cancer patients, just have lunch with them and hear a little bit about what they were going through. And the things you see on the screen are a lot of the things that I would hear firsthand. And if there's any clinicians in this room, I think I'd get an, amen, because I think they see these issues every day. Unfortunately for me, all of these things that you see on the screen also lead to a poor member experience, but they also lead to increased costs. Specifically more inpatient events, more admissions, more emergency visits, and then just uninformed care decisions. And so from a care perspective, it's something that we have to look at and we have to solve, but it's also something that creates tremendous opportunity to create value there. And so oncology and NeauxCo, what do we do? First, we start with low-hanging fruit, and we start with acute care. And address those member opportunities that we just talked about. And what's interesting is when you look at all value-based care groups or verticals in the country that have made this shift in value-based care, they've always started with acute care, right? They've always started looking at the patient holistically and saying, how can we solve this low-hanging fruit? Because it's something that everyone can agree that we want to do, right? We want to reduce admissions. We want to create a better member experience. Fortunately for us, there's enough savings there where if you can create savings, you can also share those savings with the oncologist. So that's what we look to do. We start with acute care. Sometimes we look at coding within Medicare Advantage. Both those are leakage opportunities. We take those dollars and then we share them with the oncologist. And then frankly, we ask for their help to do other things, specifically help us be able to identify patients earlier on, and then also help us to have more goal concordant care at end of life. As I mentioned before, we're a risk-bearing organization, so we do oftentimes guarantee savings as we take on these risk contracts. When you think about the kind of the three components of our solution, consider this like a menu of sorts that we flex up and down as we go to different regions that require different, I guess, just things with each region. But the first of which is tech-enabled care. So at the core, that's actionable insights that we can provide our care team and the members and the oncologists for how to identify high-risk members and ultimately address both their clinical and their non-clinical needs. The second is localized resources. So these are boots on the ground. That's both clinical and non-clinical resources. So we'll talk about it, but it's community workers, oncology nurses, et cetera. We're very intentional about deploying localized resources wherever we can and whatever market we can, because as we look at the literature, it's just very clear that localized resources drive about 2 to 3x more savings than digital-only models, and so we make sure that we're local when we can. And then the last is how we work with the oncologists, both through integrating with them and then also sharing savings with them. And so we'll dive into each of these kind of three components more here. As I mentioned before, normally we've got our medical team going through some of these slides, but I want to talk a little bit about our care team. Our care team and our interventions are all based from evidence-based studies coming out of OCM. So OCM over the last 5-6 years, you did see a lot of groups who were able to reduce both acute care, and so these are some of those organizations on the screen. But there was a few common themes that we saw across all of these groups. The first was a focus on social needs in the use of community workers and boots on the ground. So some examples of what these community workers would do across these models: they would look for medication pickup, they would help with transportation, they would do grocery deliveries, welfare check-ins, health risk assessments. All of these things help us really be able to engage our members consistently, help us be a trusted resources for those members, and also be able to identify gaps in care and be able to address those cares. Outside of the non-clinical side, there's also obviously clinical resources that we have to incorporate and we have to better invest in. And so a lot of the clinical teams are looking both local and virtual to really conduct solid onboarding sessions, do regular check-ins with members, and to be able to identify urgent care needs and triage those effectively. And so our goal through these care team, we'll go over the savings kind of towards the end of the presentation. We believe we could have roughly a 40% reduction in acute care savings, which would amount to about $12K of savings for the average Medicare Advantage member. And so care team is obviously a key part of our platform. But outside of our care team, obviously how we work with, providers is the other part of the equation. And so how we do that is through our model, which we call a frictionless partnership model. Our goal with this model is for it to be a stepping stone for every oncologist to participate in a value-based arrangement. That includes academic medical centers and integrated health systems, so some of the more fee-for-service groups in the country. And so how we describe how we might work with them, the underlying feedback we've heard from oncology groups and why they do not participate in value-based models is the juice isn't worth the squeeze. They're saying, I'm asked to do too much and I'm not getting paid enough. And so so there's kind of two ways you can address that, right? The first is you can squeeze less, and the second is you can give more juice, right? And so we look to do a little bit of both. So starting with squeezing less, the first is we seamlessly integrate. We don't ask a ton of our oncologists. We integrate in with their existing workflows, and we deploy those wraparound interventions that you saw on the previous slides. But the second is more juice. So we create an upside-only shared savings model, and we go and offer 4 to 5 simplified value-based care KPIs where we reward the oncologist for what we consider to be no-brainer value-based cancer care. A lot of those opportunities are at early detection at end of life, not necessarily treatment plans, but that's because where we see key opportunities to create value and save money. This is actually something, I don't know what you guys know about the kidney space, but we sold from the kidney value-based care players. They would go to the nephrologist with a very simple value prop. They say, we want you to identify CKD 3B members. We want you to do more transplants. We want you to do more home dialysis. And they would quantify a dollar amount to each of those. And it was something very easy that the nephrologist could understand, and they knew what to optimize for within their practice. And so we look to do a simplified model also within the oncology space. Going back to this slide, some of them are a little out of order, sorry. This is, this types of shared savings model that's really an entry point, I think, to the average academic medical center and integrated health system. is I think particularly important in this region. When we look at this region, there's a lot of academic medical centers, a lot of integrated practices. And historically, frankly, there wasn't a lot of adoption within OCM and EOM, which is totally fine and understandable and speaks to some of the challenges that we talked about that we're trying to address. And so our model is really optimized, I think, for this region and to work with practices that we see within these regions. We've had the opportunity to share this with oncology groups around the country and a few within Louisiana as well. Overall, the model has been very well received. I think the groups appreciate the operational investment that we're making in their practice through those resources that you saw. They love being guided how to, take, I think, small steps to high value care. And then, of course, they love the shared savings model that's upside only. And I did want to call out, not to specifically call out any of our competitors, but we've seen a few value-based care organizations kind of stood up over the past few years, and almost all of those are primarily tailored for community oncology groups. And that's not to say there's anything wrong with those models. And working with community groups, I think is a huge opportunity. But we also don't want to overlook, academic medical centers and integrated health systems, right? Change can be harder at some of these organizations, but that's specifically what we've built this shared savings model to kind of tackle. And so I just wanted to call that out specifically as we think through this region. And so I guess in closing, I know we've got the band coming up and happy hour, and so don't want to spend too much time. Certainly happy to answer some clinical questions around acute care reduction and others. But what we see as we look at the average kind of Medicare Advantage patient, see about 20K of value creation to be captured here. Most of that is not through drug. Most of that's through acute care reductions, about 12K of that. We see about, for Medicare Advantage, there's a documentation opportunity. Typically, you have a diagnosis, and the cancer patient immediately gets transferred to the specialist, and comorbidities aren't coded properly, which impacts reimbursement. So there's an opportunity there. And then lastly, goal concordant care inside of care savings, could save dollars as well. But as we mentioned before, all of these are savings that I think are incremental to, what the traditional workflows have with And so we believe it's a big opportunity here, and we're excited to continue to build out this platform. As far as where we are, last slide, just from a company perspective, we are negotiating kind of contracts with payers and risk-bearing provider groups from around the country. There's 3 in particular that we're advanced stages on. Between those contracts, it's about $250 million of spend under management that we're negotiating right now over the next few months. All of those have a contract go live we're looking at Q1 2025. And so as we think about kind of our team, we're continuing to build out the team. We've also got a really good set of clinical advisors and founders that have helped us in our early stages, but looking to build out the team a little bit more over the next year as we look to go live with those plans in Q1 2025. And so, that's what we have today. I just wanted to thank you guys again for coming. Happy to answer any clinical questions about our model or dive into market landscapes. Go ahead. Yeah, so our traditional kind of go-to-market is we traditionally start with payer just to make sure that there's an overall interest in our model, and then we work downstream with the oncology groups. There are some markets where it makes sense to really figure out what that shared savings model looks like with the oncologist first and then bring that to the payer. If there's a really large provider group, that makes sense. But traditionally, we make sure that there's good alignment from the payer before kind of working downstream. We consider our platform fairly provider agnostic, because it's an upside only model. We really try to integrate with every oncologist that our members see.
You want to expand to
Yeah, happy to talk to anyone here. I've got business cards. Whether it's, one of the reasons why we did want to come down here is meet with the providers in the region. Obviously, Louisiana is a market that we're very passionate about. If you were to have me rank, top 5 states, I think Louisiana would easily be in the top 5. Plus, the food helps, man. I had some muffulettas last night, and I'm happy. So, any other questions? Awesome. Well, thank you guys for having me. I've got business cards. My son has a birthday party, so I have to head to the airport, but I'll put some business cards here on the table, and thank you guys again.